I envy you because you haven't seen this talk before. Everybody else has seen parts of it. But I tried to intersperse a few new cases, so it's not exactly the same as last year. So this is a split effort. I'll talk for the first half about echo and regurgitation, then Dr. SHAH will come and talk about MRI. So let's talk about regurgitation. Briefly, what we'll do is we'll talk a little bit about guideline changes. You should all, I think, be familiar with that, but Dr. SHAH, myself, and Dr. Zogby had a fairly large effort in the latest update of the guidelines that came out, so you'll see those, and demonstrate some applications. So what is the approach to MR? You know, we often jump straight to quantitation, so one of the messages I want to give you all today is that don't forget to pause and take a second and ask why there's regurgitation. So the etiology, the mechanism, conceptually should come before the quantitation, okay? And what I want to show you is that the tools that you use for the quantitation should depend on the etiology and the mechanism. So it doesn't make sense to figure that out after. All right, so the approach really should focus on, you know, looking at a jet, whether it's echo or CMR or anything else. You're really asking a series of questions. What's the mechanism? Next reasonable question is, what's the timing of this event? Is it early systolic, holosystolic, late systolic? And then ultimately, once you figured all that out, then you think about all the tools we have and we can apply, and which ones should we use? So, you know, in the valve clinic, we see referrals from all over the country, all over the state, and it's incredible how often the echo report will say, you know, structurally normal valve, severe regurgitation. Structurally normal valve, everything's fine except for the function is completely backwards. And that's just nobody stopping and taking a second and really, you know, making the connection. You've got to explain why there is this leak, not just say how bad the leak is, okay? So in terms of the challenges with echo, this is sort of one of the reasons why we quantitate. And this is a paper I like to show is from a few years ago. And all they did is they took a large volume echo lab in the UK, and what they did is they test the inter-observer variability of the same color Doppler image. So what they did was they basically presented this image. So a 4-chamber color Doppler of MR. See it across the top. And they varied whether it was preceded by clips that showed more severe or it was preceded by clips that showed less severe. And they looked at sort of the order of the clip presentation and asked, you know, how good are these senior experienced echocardiographers at interpreting the same clip the same way? And it was a little shocking. So 1 of the 12 gave it the same grade every time. So the point is, it is subjective. We don't think about what time of day we're interpreting, how tired we are, how hydrated we are, what the previous 10 MR quantitation look like. So we all look at color. We all pretend we don't, but we all do. It's a little like echo pornography. But the problem is we got to get past that, and we have to actually quantitate. All right, so this is a little bit about mechanism. Look at these images. So the first one here, holosystolic functional MR. We don't often use color M mode, but just to demonstrate that MR is not always the same. On the color M mode, you can clearly see it's an event that lasts throughout all of systole. Okay, this is a completely different mechanism, different patient. This is prolapse, 4-chamber view shown. It's still holosystolic. So prolapse doesn't necessarily mean an end systolic event. If it's bad prolapse, you can start to regurgitate right from the beginning. So 2 holosystolics of completely different etiologies. But then this one is a different form of prolapse. You can see it's just a posterior leaflet prolapse. It takes time to develop. You've got a long gap between the QRS and the onset of regurgitant flow. So this is simply late systolic MR. So the point of it is you have to think about it. You have to look for timing in addition to mechanism. So what's the approach really? So is it severe ultimately? You need to know the mechanism. I've harped about that. And the other thing in terms of our quantitation is what is the consequence? Does it make sense? If you're saying there's a severe valve lesion and it's been present for a bunch of serial echoes, you should see chamber enlargement. You should see atrial arrhythmias. You should see pulmonary hypertension. You should see other things that go along with it. So it's not just stopping at the color flow and moving on. It's what's the consequence of this disease. And then, you know, from the practical perspective, another question to be answered in this approach is it time for surgery? And what else can I say about this lesion to help people fix it? So where in this current era, are there features that would preclude a mitral clip application? Is it ideal for a mitral clip? Does it look like it's an isolated lesion where surgery should be reasonable? Is it a Barlow's valve that should only be approached for repair by the highest volume, best quality surgeon you have? So these are some of the issues. Again, worst case scenario is structural abnormal, severe dysfunction. That's the low bar, and we have to do a lot better than that. Okay, so this is a pretty straightforward case, knowing anatomy to understand the mechanism. Hard to just recognize what the mechanism is if you don't really understand the anatomy behind the function. So this is a graphic you've seen many times, and we see it a lot. We see it all the time in the echo lab. We see it yesterday in the mitral clip case. Normal ventricle on the left, pap muscles and cords are in the right place, cords are of the right length, easy, complete coaptation of the leaflets. So what happens here is not pap muscle ischemia or necessarily pap muscle dysfunction, it's ischemia and remodeling of the wall that the pap muscle is attached to. So the effect is that the pap muscle, in this case, is apically and laterally displaced. The cords don't get longer to compensate, so now you have this tethering, and this is a nice depiction. It's pretty small, but I'll show you an echo in a second. It shows actually the strut cord sort of puckering that anterior leaflet. It's not a rare bird. This is an example I like to show because this was a case where actually the segmental wall motion had been missed. And then you turn the color on in this case and you see there's MR. And this, by simply asking the question, as I've harped on, why is there MR, you look at it again and you say, well, there's this little hooking here of the anterior leaflet, and oh yeah, there's a little bit of hypokinesis here on the infralateral wall. So sometimes the MR actually reminds us to look for wall motion. So mechanism. Some obvious examples of functional MR. Bailey, is the ventricle is the problem. The subvalvular apparatus has been distorted. Cords are now in the relatively either too short or wrong angle, and the leaflet gets pulled apart. And you see this tenting. And there's good data from 2D and 3D studies, so the greater this tenting area, the more severe the mitral regurgitation. Sort of makes sense. You're transitioning from this nice 10 millimeter coaptation zone to the tips touching, which is not as competent, to no tips touching. Here's a case that some of you will not have seen. This is somebody referred to us, 91 years old, had a remote history of CABG, comes in now with dyspnea. And look at that valve. Great example of that hook in that anterior leaflet. And that's this strut cord. You don't see the cord very well, but you see the effect of the cord. There's a strut cord coming up here to the mid-belly of that anterior leaflet. So that's asymmetric tethering. So not all functional MR is a central jet. That's fallacy number one. Functional MR can be asymmetric. Okay? And you see no coaptation. There's tethering of the posterior leaflet. It's kind of vertically displaced. And the anterior leaflet is hooked. You don't really need to turn the color on to know that that MR is going to be severe. But the other problem is here, is the aortic valve. In this case, the aortic valve is severely stenotic. So this is that double whammy. How do we figure this out? And what do you treat first? Well, we were sort of in this dilemma. Prohibitive surgical risk at this age and with this history. We said, oops, I'm sorry, I want to show you that 3D view. There we go. Doesn't add anything, but it looks nice. And it simply shows that hole. So nicely depicted functional MR, big central defect, with an aortic valve that doesn't open. So that's a tough scenario. So I show this case to sort of emphasize that we don't always know what to do with these lesions. So this is the same patient. This is the pulmonary vein sample. You can see there's a little bit of slight S reversal, and then there's the D wave. And this is what the color looks like in that case. I showed you the hole already, so it's not surprising there's significant MR. We were contemplating TAVR. We said, well, we're not really sure. Ideally, let's think, if we actually release the obstruction to the ventricle, open up the aortic valve, that's less pressure on the mitral valve, the mitral valve is going to get better. The MR would get better simply by opening the aortic valve. Kind of makes sense. Let's go ahead and try that. Here's the balloon valvuloplasty on the aortic valve. And then here's what happened. The pulmonary vein flow reversal got worse. The signal got stronger, but importantly, the S wave reversal got deeper. The ventricle became more sick, and the MR got a lot worse. And that's actually the acute effect, if you think through all the steps of what a valvuloplasty is. You've got to rapidly pace for several seconds. You obstruct all flow. You turn cardiac output to 0 for a few minutes. And functional MR is very volume dependent. So in the end, although you're acutely relieving obstruction, to get there you have to overload the ventricle for a few seconds or a minute or so. And a sick heart takes a long time to recover from that. So acutely, the MR actually got a whole lot worse from that endeavor. Ultimately, we realized an aortic intervention alone would not work. We didn't like what we were seeing. We did a mitral clip. Patient got a little bit better, got out of hospital, but ultimately actually didn't have a good functional improvement until he did go on to get his TAVR. So this patient ultimately needed both, and that's one of the things we struggle with is which one first. So mechanism matters. That was a case of functional MR and pressure overload. Some examples of some of the extremes. So primary leaflet dysfunction, that's the typical myxomatous valve dysfunction. This one here is a P2 prolapse, and you see a little cord here, so that's a flail P2. It's a ruptured cord. This is more of a Barlow, sort of lumpy, bumpy, with multiple leaflets all prolapsing. This is a sick ventricle. This is like the case I showed you. This is often termed prolapse incorrectly. You see that the tips of the anterior leaflet is behind the posterior leaflet, but that's a pseudoprolapse. Neither of the leaflet tips actually extend past the annulus. So that's actually functional MR, it's not prolapse. This is sort of the ultimate ventricular problem, is a pap muscle rupture. There's two heads of the pap muscle, post-ischemia. So that was a lot of MR. And this is the true mixed. Some would argue, you have to call it one or the other, but there really are times when it's truly mixed disease. Lumpy, bumpy valve with poor coaptation in a sick ventricle. That's mixed. So recognizing all these matters, and if we're going to do some of the quantitation, this has to be commented upon, or at least considered. So here's an example of functional MR. This is looking from the ventricle up at the mitral valve in systole. You see it's got kind of a smiley face. The aortic valve is also open, so this is clearly systole. And the color is wide in this view, more narrow in this view, crescent-shaped in the short axis. Why is it important to recognize that? So we know that more and more with 3D echo. We see this all the time now. This is not the exception. This is more the rule with functional MR. Because if you apply, and this is the sort of flow convergence in 3D, let's apply our 2D Pisa hemisphere and do the math, assuming hemispheric Pisa, you're actually going to estimate an EROA that looks like this. All right, that's what you get is a circular EOA from a hemispheric assumption. In this case, it's got nothing to do with a hemisphere. So just a sort of a graphic depiction of how we underestimate MR conceivably by using the wrong tool in this case without recognizing what the etiology is. So there's a bunch of different tools, and we'll talk about them briefly. Obviously, regurgitant jet area we'll talk about. And I think these two really should be talked about together, the vena contracta and the flow convergence. They really are, they're the proximal flow event, and that's really where the money is. When you're trying to quantitate one of these lesions, the best place to spend your imaging energy and your mental energy is what's the flow convergence and what's happening right through the orifice. That's the stuff that's most reproducible. That's the stuff that's most robust for quantitation. The least robust is where is the jet, how big is it, and how far does it go back. The jet is subject, as we'll talk about, to multiple other features, but the proximal stuff is really where the key is. And when I'm working with fellows during TEs, for example, there tends to be an immediate emphasis on seeing the jet in the back of the atria and focusing on where the jet goes and how far it is at the back. And when I get referral echoes from all over the place, very little time is actually spent showing the origin of the jet. But those are the money shots. That's what we really need to see is where does the jet start from? The proximal jet is more important than the distal jet. So try to remember that. So, all right, so some color Doppler features. Right, so what is this subject to? The color flow, right? It's a velocity map. It's not a volume map. It's subject to the actual velocity, which is driven by the pressure. So the pressure gradient affects the velocity. The ventricular health, of course, affects that as well. The chamber compliance, is the atria huge? Is the atria small? That'll all affect the pressure gradient for the same amount of MR. So the same amount of MR into a large atria might have a different velocity, therefore a different color profile than the same amount of MR into a smaller ventricle. So that tends to relate to the acuity of the problem, but not always. Sometimes you can have MR in an AF atria. So the size of the atria and the compliance matter. And the other thing I'll mention is whether the jet is central or wall hugging, and I'll tell you in a second why that's important. So the concept behind, for example, a central one is the flow momentum. So the higher the velocity, the more the jet will extend into the receiving chamber. So that's why simply looking at, the percent of the jet relative to the percent of the atria, very weak because of things like flow momentum. Higher pressure, you take the same patient for the same amount of volume, increase the momentum, the jet appears bigger, although the actual regurgitant volume may not be any bigger. This is an example of that idea. So here's, this is sort of a late at night weekend echo. Patient's not doing well, what's going on? There's a flopper here, a dangler, a wiggler, whatever you want to call it. It doesn't look right. Big endocarditis, maybe, I don't know, patient's intubated, no history, don't know what this is. Color is sort of chaotic, a little underwhelming. Let's put some CW on. Well, it's got similar density as the antegrade, but it's not too bad. It's only 3.5, so reassuring. Not so much, right? What it tells you is that there's no, the pressure gradient between the LV and the LA is basically non-existent. Pressure gradient, whenever this velocity is less than 5 meters, you've either got a very sick ventricle or you've got no competent mitral valve, because you should have a big pressure gradient between the LA and the LV. And when you don't, this is basically a pap muscle rupture. So the key to the pap muscle rupture is dense, triangular, sort of early equilibration of the gradient, the pressure across those chambers. But a very underwhelming color because the color just reflects the velocity, and the velocity in this case is low, yet the amount of regurgitation is enormous. So these are the extreme scenario to kind of emphasize the point. The other issue to recognize with color is the concept of entrainment. So entrainment is simply, let's say for example this center bar here is the amount of regurgitant volume that actually goes into the atria, but because of entrainment, it actually pulls the red cells that are already there. So red cells that aren't regurgitant get pulled into the stream of the true regurgitant volume and add to a velocity. So you might appear that the jet is the entire width of all that, when in fact it's really just the center. So the concept of entrainment is a big issue with color, a little more important on a central jet. So central jets, we sort of recognize there's a bit of fudge factor required on a central jet. It may not be as big as it looks. And the corollary is a wall-hugging jet, we have to fudge as well. Why do we fudge wall-hugging jets? So the Coanda principle, we've all seen, you pour a lemonade jug on a hot summer day and all the liquid dribbles down the side. So the tendency of a fluid to be attracted to a surface and want to stick to that surface is basically the Coanda effect. Henry Coanda first described it. It has a relation to aerodynamics. That's why the jet wash shoots across the top of the wing and then goes down the wing, and that actually gives lift. So that was the first application. On Twitter, for those of you on Twitter, if anybody follows Heart to Prove, who I'm sure is a Russian troll, unless you know him and he's in this room, there's a great video of a wine bottle with a candle on the other side of it, and somebody blows. You blow into the wine bottle, and the candle's on the other side, and the candle goes up, because the breath tracks around the wine bottle and blows out the candle. So that's a great example of the tendency of a fluid, including air or blood, to track a surface. So that's really what the Coanda is. Why does it matter to us? Because it gets something like this. So you have this wall-hugging jet, that there's fluid structure interaction, there's slowing down, and this fluid just wants to kind of stay there as well. So, when you're used to quantitating off a central jet, now you hug a wall, we know there's a fudge factor. We don't know quite what that fudge factor should be, but beware the wall hugging, and in general, if it's a long one like this that goes all the way back, it's impressive. And then you should focus on the proximal event. Look at the vena contracta. If you can do an angle correction, which is difficult on a Pisa, maybe some effort there. Okay, so that's, we talked about that. So the Pisa, appropriate, and the assumptions of the Pisa are, the mathematical assumptions are that the hole you're trying to estimate is a pinhole. It's never a pinhole for us, but the assumption that works from Pisa is if the hole is circular or roughly circular. So if it's a roughly circular defect, and your images are good, which we'll show you, then the Pisa concept generally makes sense, because if you're going through a circular hole, as the flow accelerates towards it, it'll roughly form a hemisphere. So that's the idea. This is an example. Not a great example, actually, because this is probably some tethering. So this is an element of functional MR, but we still see a Pisa happening here. The concepts, for those who sometimes forget, you have to do the baseline shift in the direction of the flow. So on a transthoracic, you shift down. On a TE, you shift up. That actually gets forgotten by some. Here's the math. So the isosurface area is 2 pi r squared. You can calculate the regurgitant flow by taking this surface area here, multiplying it by the aliasing velocity. So that's the velocity of that surface area. So that area times that velocity equals regurgitant flow. You can derive the area, which is this unknown here, by taking the flow and dividing it by the peak velocity of the jet. And then you can take all of that, multiply it by the VTI of the CW, and get the regurgitant volume. So this is kind of what that looks like when you apply it. We've done this all the time. We don't have to go through all this. The one thing that people tend to forget when they try to do the math, you plug it into DigiView. It's pretty easy. It'll walk you through it. On your board exams, you won't be able to do that. So remember, the issue is you follow the units, recognizing centimeters squared times centimeters per second divided by centimeters per second is how you get to centimeters squared. So think through the units when you get lost in what you're supposed to be doing. Okay, just an example of what that looks like. You can also do it by TE. There's no physics reason why you can't apply Pisa by TE. So that's just an example of that. You often have a very nice CW. One of the challenges, of course, with Pisa is that you need the CW component to derive the regurgitant volume. If it's a very eccentric wall-hugging jet, that angulation can be very challenging. And if you don't have it, you can sometimes just assume 5 meters for the velocity. You might be able to assume a TVI. That's hard to do. So it is challenging for a wall-hugging jet to use the Pisa properly. Vena contracta, shown here. This is the concept. I like this graphic from
You may want to mention, Steve, where do you measure the diameter for Pisa?
Okay. Yes. So it's
That's an issue. That's a beautiful example.
this guy here. All right. So here we go. My arrow keeps disappearing. So where would you do it? So you want to do it where the aliasing velocity changes colors. So you want to, the surface you're taking has to correspond to the velocity that you're determining based on your baseline shift. So this is pretty small, but where the blue-yellow interface occurs is where the velocity changes. So that's the velocity you plug into the equation. So that has to be the same place that you measure. I'm sorry, my mouse keeps disappearing. But when in doubt, when you have a rainbow and it's hard to determine where to put the top end, just look, where is your velocity change color? That last color to the color above, that interface is the same that you've got to match on the Pisa. That's how the math makes sense. Is that what you meant?
Yeah, but the neck is the big issue.
Oh, you're the tissue part,
So,
okay.
I mean, is where do you, the start is easy because that's at the beginning of your aliasing, right? And there's quite a bit of controversy as to where do you measure the neck.
So where you don't,
I'm going to talk through this because otherwise people are not hearing us, if you don't mind. But that's
oh, you even here?
because that took about quite a few conference calls to decide on where do you measure it. And I don't know if I can
It's there.
measure it there. Well, you see this hemisphere like this, okay? And the reason why you don't see as much color in the neck is not because the velocities are lower, it's because you're perpendicular to flow. The flow is coming in and going into the orifice, so that's why it shows like a neck. It's because of Doppler, not because the velocities are zero. But you would take it at that neck. If there is a neck, this is where you take it. If you don't have a distinct neck, you take color off and see where the coaptation of the leaflets are. And you take it at the tip of the coaptation, not at the vena contracta, at the tip of the coaptation. Okay? Vena contracta is usually lower. But that's part of, at times in the literature, there's an overestimation of color Doppler, of flow. That could be part of it, is where do you take the second measurement of that diameter.
But, correct, it's at the hole, not above the hole. Because the error I've seen is
Not above the
sometimes the neck is actually, the leaflets are here, they'll measure it this is the flow convergence. I'll stop the measurement here above the leaflets. You're supposed to be in the hole right here at that plane. Vena contracta is deeper. It's below. It's distal. But yeah, at the hole, not above it. Okay. So this is actually you can use this. This example shows it nicely. So where would you do it? If this was your flow convergence, right here. That's the hole. Whereas the vena contracta is a little more distal. And with the vena contracta, what you're getting is the flow keeps accelerating, keeps converging, and then it starts to disperse again. So flow convergence. So as it's still converging, when it gets to its narrowest portion, that in concept is the same. There's a little contraction factor, but it's basically the same as the effective orifice area. So the vena contracta area and the effective orifice area at that time point, because this is a peak instantaneous measurement, is how you measure that. Kara, you had a question? The vena contracta? Go. So on this graphic here, if this is your flow convergence, you would measure right here, where the sort of turbulent. That's where the leaflets is. That's within the hole. You can blow it up here. This is the same thing blown up. So Pisa would start out here. You would measure it to here, sort of right between the leaflets. Whereas the vena contracta is a little further down. Most of the error people make is they measured above the leaflets. So that's why you toggle color on and off if you're not sure. Have a side-by-side with and without color, and then it's usually much more obvious. Okay. So the vena contracta, even in a functional case like this, there is still a relationship, even though it's not representing linearly, perhaps, the diameter. So at a 2D across here, this is clearly a much, much bigger hole, but this vena contracta might be 5 millimeters and this one might be 2 millimeters, but it still represents, it's not as discrepant as, say, the Pisa measurement on a functional. So primary versus functional with Pisa, you can get very different answers. Vena contracta 2D, in this particular plane, which is going across basically the three-chamber view, it can still be okay. And these are the relative numbers, less than 3 millimeters is mild, greater than 7 millimeters is significant. We've talked for quite a long time at this center about vena contracta area. We're still exploring it. The concept is great. This is an example of 2 independent jets, 2 discrete vena contracta areas. You can actually measure them and get a total summation of the effective orifice area. The challenge really are technical challenges. If you change the tissue gain, you can make the hole bigger. If you have a high gain, the holes get smaller. And since it's such a small area, there's a lot of error in that measurement. So we're exploring, as we heard yesterday in a research conference, sort of software, ideally, that might be able to sort of auto-quantitate this and do it the same way every time. The concept is good, and with a lot of training, it can be reproducible, but in terms of rolling it out to widespread use, it's very difficult to use vena contracta for a lot of people, because it's highly variable and technical. Stroke volume, this is really one of our gold standards. You've seen this in I think, Dr. Q's Doppler lecture. I think this is his slide originally. I've had it now for 10 years. I'm not sure where it came from anymore, but it's the same slide. Yes. It's now just a Methodist slide. Nobody owns it. No copyright anymore. But the concept is clear. You know the diameter. You derive an area from that diameter. You measure the distance blood travels. Again, you look at the units. Stroke volume equals area times distance. That's how we get a stroke volume. Sort of graphically, the same idea. You can do the same thing on the mitral side with more challenge, and I'll show you some of that challenge in a moment. But the concept is clear that you do a diameter, you do a VTI for distance, you derive a volume, you look at what leaves the heart compared to what entered the heart, and the difference must be what goes backwards. So that's how we derive regurgent volume using Doppler methods. A lot of challenges to the application of this technique. One includes, just recognizing what it is we're measuring, knowing that the annular anatomy is not a circle. It's dynamic, it's moving, it's folding throughout the systolic phase, and it's never a circle at any point in a cardiac cycle. And that is an assumption of a single diameter that then derives an area. This was an interesting study looking at 3D, just to sort of emphasize that fact. They looked at, because we were talking about this the other day, Dr. Q, this was a 3D measurements of mitral annular area and LVOT area compared to 2D. And in this study, this was actually published now in JACE a couple of years ago. The bottom line was, compared to 2D echo measurement, the 3D derived measures The mitral angular stroke volume was smaller by 3D, the LVOT was larger by 3D, and therefore the calculated stroke volume was smaller by 3D. So that sort of suggests that there's, it really challenges the inherent assumptions of the Doppler model. That being said, it still works a lot of the time. You can still get a good sense of total cardiac output and forward Doppler stroke volume. And we've had fellows over the years that are amazing at somehow getting the numbers to always work and look good. And I'm sure it always happens the first time. Some sort of supportive data. This was a case from last week. This was somebody who had a P3 prolapse. You see it here on 3D. And this is an example of a very eccentric sort of wall-hugging jet. It shot straight across the valve and off in this direction. 2 mitral clips across that juncture. There it is there. And then this is the result. The original defect is improved. There was a secondary coaptation defect here, which corresponds anatomically to over here between P1 and P2, this area here. So we were pretty happy with the color improvements, but you want to see supportive data to make sure you're done. And this is what we saw. This was the pulmonary veins at baseline, basically D wave only, really no S wave. And then immediately after 2 clips is sort of resurrection of the S wave. So the pulmonary veins love the result. Color Doppler looked a little better. So that's just an example of the total hemodynamics and recognizing that even an acute change like this can have a dramatic improvement in physiologic flow. So, this is the table. I still like this table. This is from the guidelines more than 10 years ago now. We know all these parameters. We've talked about them many times. I want to skip this and go, because I'm into Dr. SHAH's time now. This is sort of what's in the guidelines now for the approach to MR. So step 1 is there color Doppler evidence of MR? So that's really where you start, as we all practically do. And then if the answer is yes, you look over here, and if there's criteria for severe, and they're listed here, and if there's criteria for mild, and those are listed over here, jumping through all that to the bottom line, where this becomes important and a guideline change that we should all be aware of, unlike the prior ACC-AHA guideline in 2014 that rocked the boat a little bit by providing different measurements for functional MR, this takes a step back and acknowledges, well, we're not going to quantitate them differently. The quantitation is the same. The prognostic importance may be different if the ventricle's sick versus the ventricle's healthy. So here we have these caveats in here that, you quantitate the same. You still have 3 big buckets, mild, moderate, and severe. This isn't the final version that's in the guidelines, but this is called moderate. But then over here, recognizing that if your ventricle is sick, moderate or moderately severe MR may have very bad prognostic implications. You don't need to be severe if your ventricle is sick. And then there's caveats here about sort of various cautions. And for the sake of time, because I'm into Dr. SHAH's time, I think I'll relinquish the stadium here, or the podium. Do you need any of this?
No. Okay, first off, I want to thank Steve for giving me more than just the last 10 minutes, so outstanding. So here's what we're going to talk about here. So one is, first is just talking about how do we assess valvular lesions by CMR. And really there's a few things that we want to try to do. One is assess the consequences of the lesion. 2 is a mechanism of the abnormality. And then thirdly, the severity of the regurgitation. And then talk a little about when would you actually use this in clinical settings, and then a little bit about how it compares with echo for valve assessment. So here's an example. This is kind of the basic technique that we utilize called Cine-SSFP, and this is really kind of the mainstay of what we do in most CMR for assessment of morphology as well as function. And we can use this to give us dimensions of the chamber. So we can use this to get an LV end diastolic and LV end systolic dimension. But again, recognize that's a single linear dimension that you're getting, but you can use that to get an idea of the consequences of the ventricle. But what we prefer to do in CMR is actually to look more at volumes. And the way that we generate volumes by CMR is actually by using the true Simpson's rule of disc, where essentially every single short axis slice here is imaged. These are sequential slices every 10 millimeters apart. And we make sure that we line this up so that we're starting at the base of the heart, going all the way down to the apex, and make sure that we're perpendicular to the long axis of the heart. And then as we go through and trace each of these individual slices, the area times the thickness of the slice basically computes a volume. If you add these volumes together in diastole, you generate now an end diastolic volume. You do the same thing in the systolic frame, and you generate a LV end systolic frame. And then obviously the difference between those two is going to be your stroke volume. This actually now, again, this goes back many years, and there's numerous studies really validating this, both in animals as well as in vivo and in vitro settings, showing really a very tight correlation. And here's an example of comparison of CMR volumes to casts of cadaveric hearts, showing again a very close correlation between volumes derived by CMR. And again, the advantage here is that there's no geometric assumption, so it really doesn't matter whether you have an altered geometry or shape of the ventricle. And then this is an example of how this is done in a clinical patient in our routine practice. Just using this software, we line up the end diastolic and end systolic frame, and there's actually kind of a region growing algorithm that you can use, which basically just starts with a seed point and then just keeps growing outward until you tell it to stop. And this actually now allows us to do this within just a matter of a few minutes. So it doesn't take 20 minutes to do this post-processing. This can all be done really within 5 minutes or less. And the other important thing is that because MRI uses a coordinate system, we can see exactly where this short axis slice sits in relation to different long axis views that we acquire as well. So you can make sure that you're incorporating the very basal slice of the heart to make sure you're not missing any volume, but also make sure you're not incorporating volume that's actually within the atrium. And as you do that, you're actually able to then derive these parameters here: LV end diastolic and systolic volume, LV stroke volume, LV ejection fraction. And we can use the same principle that I showed you to also look at the right ventricle for volumes and EF. And then this is what we use as kind of our basic analysis or basic methodology for assessing remodeling of the ventricle. And so in this case, based on these volumes, you'd say the LV cavity size is severely enlarged, LV systolic dysfunction is mildly decreased. Now, let's talk about mechanism a little bit. And the advantage with CMR, again, is that you can get really any imaging plane that you want to by simply moving a mouse. And so for a valve assessment, like for a mitral regurg case like this here, what we would do is not just do the standard 3-chamber view through the heart, but in fact do contiguous 3-chamber orientation cines that will interrogate more anteriorly to show us the A1-P1 interface, as well as interrogate more inferiorly to show us the A3-P3 interface. And this is just an example of what these would look like when we look at the cine images. And it allows you to localize a specific cusp that the abnormality is occurring within. And here's an example of a particular case. And if you look at this, the coaptation abnormality in this case really is down very inferiorly at the A3-P3 interface, where you can see those two leaflets don't coapt together properly. So this would be a case of a malcoaptation of the A3 scallop. Here's some data actually comparing the sensitivity and specificity of both CMR as well as transesophageal echo for identifying the abnormality. And again, this was using a surgical gold standard, so these are all patients that went to the operating room. And it showed really that both CMR and TE performed quite well at localizing the region of the abnormality as far as the specific leaflet and the specific scallop within the leaflet. The one area, obviously, where CMR was inferior was in identifying torn chordae. And again, that's because of the fact that the CMR images are taken over several cardiac cycles. And so when you have a very randomly mobile structure like torn chordae, echo is going to be better for that, for identification of that. Now, here's examples of other abnormalities. You can see here's a patient who has a posterior leaflet prolapse. Here's a patient who has actually kind of bileaflet prolapse with the classic Barlow's type abnormality. And so for MR assessment, not only for primary MR, but also for secondary MR, CMR can be very useful. Here we can see clearly there's a wall motion abnormality in the lateral wall, resulting in tethering of this posterior leaflet. And you can see a somewhat eccentric mitral regurgitation jet. And also when we couple this with our delayed enhancement scar imaging, we can see for this patient on the left-hand side, That wall motion abnormality is actually due to a large submental or large transmural infarct in that lateral wall. On the patient on the right-hand side, where you see a dilated LV and a dilated annulus, you can see there's no evidence of late gadolinium enhancement. And this is an example of a patient with really more of a non-ischemic secondary mitral regurgitation. Next, let's move on to quantification. And this, I think, is where really one of the strengths of CMR is that the methodology that we utilize is based on the stroke volume calculations that I showed you earlier, coupled with the ability to do phase contrast CMR, which is analogous to echo Doppler, where when we perform phase contrast, we actually generate two sets of images. One set of images, which is the magnitude or the anatomy. The second set of images is actually the velocity phase map, and it actually tells us both the direction of flow as well as the velocity of flow for any given pixel. Now, if you draw an ROI here, and you draw that for each phase in the cardiac cycle, and summate this together, this actually now gives you what the total volume of flow is within the cardiac cycle that's antegrade or volume of flow that's going retrograde. And in this case, we would use this information to try to actually quantify the severity of the mitral regurgitation. And the way we would do that is by solving this equation right here. So Z equals X minus Y. Essentially what we're saying is the amount of flow going backward in the left atrium, or the mitral regurgitation, is equal to the total amount of flow that's squeezed out by this ventricle. So that's the LV stroke volume minus the amount of flow that we calculate as going forward across the aortic valve, which in this case is shown as Y. So we really use our cine images to derive the stroke volume, and then use the phase contrast images to derive the flow going out forward across the aorta. And then the difference between these two is equal to your mitral regurgitant volume. Some of the advantages with this technique is it really doesn't matter if you have a non-holosystolic jet. So if the degree of regurgitation is changing throughout systole, it doesn't make a difference, because what you're getting is really integrating the total volume of reverse flow that's occurring for that systole. Eccentric jets don't matter because, again, you're not doing anything that's specific to the location of the jet itself. And if you have jets that are mobile as well, really doesn't make a difference. So again, this will be kind of a comprehensive assessment of what you would look at in mitral regurgitation, where you'd quantify the severity of the regurgitation, which in this example case here is 83 mLs, let's say. You'd quantify the LV end diastolic volume to get an idea of what the remodeling of the ventricle is. You'd quantify the LV ejection fraction. And then in addition to that, assess for right ventricular abnormalities. And then lastly, mitral regurgitant fraction is basically the mitral regurgitant volume divided by the forward flow across a mitral valve. So in this example scenario, 83 cc's is the regurgitant volume, and 47% is the regurgitant fraction. So again, we're not just qualitatively assessing, we're actually quantitatively grading the severity of the regurgitation. Now, there's a number of internal consistency checks that we utilize as well. So I told you that for mitral regurg, we use the preferred method, which is the indirect method of LV stroke volume minus the aortic outflow. But what we also do is do a secondary check by actually determining by phase contrast what is the inflow across the mitral valve. So you can actually then look at what the mitral inflow is compared to the aortic outflow, and that's a separate calculation that you can do. Again, these are just internal consistency checks to make sure that they're correct. Now, let's say for some reason your aortic outflow measurement is contaminated. Well, in those cases, you can also go to your pulmonic flow assessment. And so for a valve assessment, we're going to do all of these imaging and do all of these measures. And you could actually then compare the LV stroke volume to the PA outflow and use that as a secondary way to determine your mitral regurgitation severity. So again, multiple different kind of secondary methods that you can utilize. And then at the end of the day, in addition to regurgitant fraction and volume, you want to give a qualitative grade based on mild, moderate, or severe, based on both the regurgitant fraction and the regurgitant volume that you derive. Now, in addition to kind of the secondary methods for quantitation, there's also other methodologies that you can utilize, again, to just corroborate your findings. So one of the things you can do is actually look at the anatomic regurgitant orifice area. So this is not ERO, Rather, this is the anatomic regurgitant orifice area, ARO. And in mitral regurgitation, there was a study that demonstrated that if you just go through and measure the size of your regurgitant orifice, now the key here is you want to make sure that you've got serial short axis slices at the hole itself, at the regurgitant orifice, because again, if you're too high, the jets may start to splay out and you may get an erroneous value. But if you do this correctly, in this particular study, an ARO of greater than 0.4 had actually a fairly high sensitivity and specificity for identifying grade 3 or 4 MR using Seller's correlation by angiography. Skip past this here. And then lastly, the other things that are important, I think, is you want to look for internal consistency amongst all these things, is make sure that the remodeling changes that you see with the ventricle match the quantitative numbers that you're getting. And again, if you're getting severe mitral regurgitation, but yet you have a very small ventricle, that's a clue you have to wonder could there be an error somewhere along the way. Let's move on now to when is it that you might want to utilize it. So obviously, here's an example, and echocardiography is going to be the first line modality that you utilize, but we do know that sometimes echo may be suboptimal. Well, I started with the CMR. That's why I started with the CMR images first. So if you've got obesity, you've got lung disease, the reality is if you can't see it well, it's hard to make an assessment. The other example is that even when you have good quality images, is if there's a disconnect between your clinical history or physical exam, your 2D echo, and your Doppler findings, that's an indication that you should move on to additional testing. In fact, this is really called out specifically in the guidelines. If you look at this table from the most recent ASC guidelines, most people tend to focus on the figure up here, but look at all these little caveats as Steve pointed out as well. And again, if there's suboptimal images or if there's discordance, those are cases where you need to think about additional imaging. Another example, a very nice, beautiful image here, very eccentric jet, right? Sometimes with eccentric jets, it can be challenging. Here's another example, and this is an example of a patient who's got prolapse, really kind of Barlow's type mitral valve. And if you look at this transesophageal echo, what's the severity of the regurgitation? Well, the size of the jet is actually changing. And if you look at this slow down, you can see that very early on, there's really not much mitral regurg at all. And then boom, once you get to mid and late systole, that's when you get a huge amount of regurgitation. So the question then becomes, what's the severity of regurgitation here? If you look at a single measure, at one single frame, it could be misrepresentative of the true severity. And so obviously that's where using something like CMR, where you're just simply integrating the total volume of reverse flow that's occurring throughout the entire cardiac cycle, can be useful. And again, the guidelines have these two caveats put in there, which is eccentric jets, be careful, which is that non-holosystolic jets, be careful as well. Another example where CMR could be useful is when you've got multiple lesions. So if you have both aortic and mitral regurgitation, this is an example where the CMR method, especially this indirect method of LV stroke volume minus the aortic forward flow, works just fine. Because notice what happens when you have AI is that the AI increases your aortic forward flow and it increases your LV stroke volume. So in this equation, it cancels itself out. And so as a result, your mitral regurg assessment is not compromised by the presence of aortic regurgitation. Now, one caveat to this obviously is that's for regurgitant fraction or volume assessment. For regurgitant fraction, since it should be the reverse volume, the MR volume divided by the forward volume across the mitral valve, you'd want to subtract out the AI from your LV stroke volume to compute the mitral regurgitant fraction. Let's move on here. Other examples are when you've got prosthetic valves. So here's an example of a bioprosthetic valve with a paravalvular jet. You can see the paravalvular location of this jet on the Cine CMR. But again, the methodology that we use to compute the severity of the regurgitation really doesn't matter because we're not doing anything at the location of the valve itself. So it doesn't matter what the artifact is from the valve. As long as you can draw these contours of the LV to determine LV stroke volume, and as long as you can do aortic forward flow, you can compute the mitral regurgitant volume and fraction. Same thing for a mitral clip as well. And you can see here's an example of a patient with a mitral clip where you can see there's clearly some artifact around the clip itself, but it really doesn't impair your ability to contour the endocardial borders, and it really doesn't impair your ability to do phase contrast in the ascending aorta. And this is a technique that we would utilize, again, for mitral regurg assessment. Okay, so last is how does echo compare with CMR? So there's, this study came out a couple years ago, which looked at intra and inter-observer variability in assessment of mitral and aortic regurgitation. And it showed that although both techniques are reasonably good with correlation coefficients in the high 0.8s, CMR seemed to be a little bit tighter with correlation coefficients in about the 0.95 range or so, both for aortic as well as mitral regurgitation. And they showed similar data for both intra and inter-observer variability. Next, I'm not going to go into this too much because obviously, we could get everybody's head turned hot here. But this came out a couple years ago, and certainly there's issues with any study, but this at least I think was very provocative in the idea that this was a cohort of patients that they looked at where they compared assessment of mitral regurgitation by CMR as well as by echo. And then, obviously, since there's no true gold standard, I mean, one of the things I noticed clearly is that there's discrepancy. The correlation is not terrible. It's about 0.7 correlation between mitral regurg volume by CMR and by echo. But you can see in the Bland-Altman there is, discrepancy between the two modalities. Some of this, obviously, is because mitral regurg we know is a dynamic disease, and it can change from time that you image to time that you image. But in the absence of a true gold standard, what they tried to utilize was to say, well, what's the reverse remodeling that happens to the ventricle? And at least in this study, they demonstrated a fairly tight correlation between the mitral regurgitant volume at baseline and the magnitude of reduction in LV end diastolic volume that occurred after surgical mitral valve repair. Now, let me move on to some prognostic data. And this came out just last year as well. This was from a European group where they looked at a series of patients with mitral regurgitation that were being followed medically and did kind of serial longitudinal CMRs on these patients every year. And the objective was really, one, to predict adverse outcome, or can the CMR findings help predict adverse outcome? And obviously the adverse outcome here was either mortality or the need for mitral valve surgery. And the CMR findings here for this particular project were blinded, so the referring physicians were not aware of it. And what they did find, in fact, was that a CMR regurgitant volume of greater than 55 cc's was associated with a high likelihood of these patients going on to either have mortality or to need mitral valve repair surgery performed. Pardon me?
It's not modal.
It's not what?
Moral.
Moral.
Morality instead of mortality.
Oh, is it? Well, yeah.
If you achieve morality, that's an adverse outcome.
Well, yeah, I guess I was trying to make a political statement here. No comments on Washington, D.C. and our presidency and everything else, but let's move on here. The other thing I also noticed again was if you looked at size of the ventricle as well, LV end diastolic volume indexes of greater than 100 by CMR were associated with higher likelihood of eventually going on to get mitral valve repair or having mortality. And so again, these are all findings that we've seen in the echo world, but now there's at least outcomes data with regard to CMR as well. Now, what about for aortic regurgitation? So again, the guidelines will point out that when you're using echocardiography, if all your parameters line up, it's pretty clear-cut mild. If all your parameters line up on the severe side, it's pretty clear-cut severe. But in cases where there's discrepancy or things don't quite line up, that's when you may want to move on to additional testing. And so the way that CMR does assessment of AI is really using kind of a direct methodology. So essentially you're going to place this phase contrast imaging plane directly above the aortic valve. And then you'll determine what the forward volume is, And then as this valve shuts or is supposed to shut, the blood flow that's going backward comes back across this imaging plane, and you actually capture now a reverse volume. And again, if you draw this ROI for each phase, you can actually integrate that and determine what the total reverse volume is for aortic regurgitation. So with this methodology, it's fairly straightforward as long as you can image above the aortic valve plane. Now, there can be some caveats to this. For example, if for some reason in patients who have arrhythmias and you don't get a good diastolic phase where you can't capture all of diastole because of AFib or something, you can use, again, these kind of secondary indirect methods, which is to compare the LVOT forward flow. So we can measure flow at the LVOT level as well, just below the valve, and compare that to the net pulmonic flow. And again, that equation can be useful to determine your aortic regurgitant severity. And then lastly, as a last resort, as long as there's no other regurgitant lesions, you could actually compare the LV stroke volume to the RV stroke volume. But again, recognize that that methodology will not be accurate if you have coexisting MR or coexisting TR as well. And then also, again, from an anatomic standpoint, you could look at the size of the orifice, the anatomic regurgitant orifice, and in this particular study, they were able to demonstrate that a ARO of greater than 0.28 was associated with grade 3 or 4 regurgitation, and then a ARO of greater than 0.4 was associated with grade 4 aortic regurgitation. So, and then lastly also, we can also use this phase contrast technique in the descending aorta and actually look for holodiastolic flow reversal in the descending aorta, just like you would in echocardiography. And in this one particular study, they demonstrated, in fact, that having holodiastolic flow reversal in the descending aorta had fairly high sensitivity and specificity for, again, grade 3 or 4 aortic regurgitation. Lastly, with AI, you also want to look at the valve itself, look to see if there's a bicuspid valve, and if there is, look for associated aortic aneurysm, as well as associated aortic coarctation. And then in patients with TAVR, paravalvular regurgitation in a TAVR valve, there's actually a study that came out just last year where they quantified aortic regurgitation severity using phase contrast by simply placing an imaging volume above the location of the TAVR valve. And they were able to demonstrate that patients who had moderate or severe, again, greater than 30% regurgitant fraction of paravalvular AI post-TAVR had a worse all-cause mortality as well as worse mortality and heart failure hospitalization. And then let me skip past here in the interest of time. And then lastly, touch on the right-sided valve lesions, tricuspid regurgitation. So again, the same method that we use for mitral regurgitation, we would apply that to the right side and compare the RV stroke volume to the pulmonic forward flow and use that to quantify tricuspid regurgitant volume and tricuspid regurgitant fraction. And then for pulmonic regurgitation, we would use the direct methodology where we would simply measure flow beyond the pulmonic valve and look for the reverse flow using phase contrast and quantify pulmonic regurgitation that way. And then obviously the other advantages are, with CMR are that you can image the pulmonic valve very nicely. And here's a nice example of a patient with a quadricuspid pulmonic valve seen just on regular cine CMR techniques. So to wrap up, one is CMR indicated. I think clearly in patients who have suboptimal echo images, patients where there's a discordance between your history, physical exam, 2D echo, and Doppler findings, in patients where there's eccentric regurgitant jets where it may be hard by echocardiography, or in patients where there's non-holosystolic jets, those are scenarios where CMR can be useful. Also in people with multiple jets, and then also in people where you're trying to get an assessment of the consequences of the valve lesion, i.e. remodeling. As we talked about already, CMR is outstanding for assessing LV and LA volumes. And then for patients where you want to get an assessment of myocardial viability and scar, CMR is helpful as well. So thank you for your attention. And then Steve and I will be glad to take any questions you may have. Yep, Dr. Q.
I'd like to make a comment and a question.
Okay.
Take comment.
Microphone? Yep.
A comment and a question. The comment is for the fellows because this is something that clinical is very important. We don't think too much about it, but often it can be a cause of symptoms. So you have a patient with a normal EF, okay? Ventricle looks okay. You get a 25 cc's of regurgitant volume for mitral regurg. We all would consider that mild, not pay attention to. You get a 25 ml regurgitant volume for AI. We would all consider that relatively mild. What if the patient has 25 cc's of regurgitant volume on both valves? That's now a 50 cc total regurgitant volume. So sometimes you have these mixed lesions. They can be really tough at times to relate one valve to symptoms because you have to think now in terms of total regurgitant volume and total regurgitant fraction. Actually, MRI can be very helpful for that. And I wonder if you guys sometimes might not want to report a total regurgitant volume, although you can do it from the report. I mean, a clinician can derive it. But it's a concept that we have to think about because sometimes these patients with two kind of mild or moderate lesions can be quite symptomatic. Then the next question is, what do you repair first? You know, that's a separate topic for discussion. But think about that. That's one clinical scenario that can be a problem. Question to you is, one of your strengths is you have these multiple methods for internal control. Do you have a hierarchy to manage discrepancies? Because there are. I have seen some of your reports where LV stroke volume minus RV stroke volume have a different value than the phase contract. So how do you, what hierarchy you use to manage those discrepancies?
Yeah, so that's a good question. So, and again, these are some of the things that when fellows rotate through the CMR labs and we go through cases, you go through this. So if it's for mitral regurg assessment, obviously the first step is to make sure that the primary data quality is good. So as long as you have a good phase contrast at the aortic valve level where there's not a breath hold or arrhythmia artifact, where there's not problems with truncating parts of the cardiac cycle, then the preferred method is to look at the LV stroke volume minus the aortic outflow. So that's the methodology that we utilize as kind of the highest level. And then if there's some issues with that, that's when then we look at the secondary comparisons, which is LV stroke volume to PA outflow, or look at mitral inflow to the aortic outflow. Now, an example of where in the end we go back to that first method is, let's say, for example, by LV stroke volume and aortic outflow, I get 20 cc's. But when I look at my mitral inflow, it's telling me the discrepancy is much higher. What I used to do with that information is say, let me go back and double check my tracings of my LV stroke volume, right? Because that's one of the sources of error that can occur is if you didn't incorporate all the volume, if you didn't get all the way to the very base of the heart, or if you didn't get the right frame for end systole, right? So you're not capturing the very smallest volume, or you're not capturing the right frame for end diastole, so you're not getting the very biggest volume. Any of those things can lead to errors in the stroke volume calculation. So what we use is these other things is actually caused me to go back and say, let's go back to the preferred method, but let's go back and maybe see if there needs to be adjustment made to the tracings. And you know, the fellows can tell you probably, even with very good techs that we have here, where we're doing large numbers of these cases, we still adjust the tracings that the techs do quite frequently. I would say, 80% of the time. So, that's one of the caveats. I think that, for valve assessment, that's the one thing I've seen when you try to translate this out in the community. A lot of labs that start doing CMR to begin with, especially a lot of labs that don't have a lot of experience with it, they're used to just kind of having the techs do the tracing, and nobody goes back and really double checks that tracing, and that's key, because a 20 cc difference in your LV stroke volume tracing can take your MR from mild to severe, so it can be a huge difference.
Question
Question for you. I've seen some cases where phase contrast gives some numbers that don't make any sense. And I'll take an example that I've seen where significant AI, that the stroke volume forward and backward is quite impressive. And yet these numbers are small. So your regurgitant fraction is still decent, but the numbers are small. What could be the error there?
Wait, let me make sure I understand. So the
Phase contrast is underestimating flow, true flow.
Okay, and then that's based
So
on,
where could that be? Where could that issue be?
And then you're talking about for aortic regurg or for mitral regurg?
Aortic regurg.
Okay. So yeah, so that's a very good, and that's one of the slides I took out in the interest of time. Where you do your, for AI assessment, notice what I showed you on the graph was measuring it in the aortic root, right, just above the valve. There's actually a study that was done where if you go higher up the aorta, your reverse volume gets less and less and less, right? And that difference can be about 10 to 15 cc difference. And in this particular study, compared at the level of the aortic root to the higher up in the, to almost a mid-ascending aorta, the difference there was about 15 cc. So one of the reasons is, depending upon which particular phase contrast location you're looking at. So that's why for AI case, what we'll typically do is do it at the mid-ascending aorta, where we use for the forward flow assessment, but do an extra one specifically at the aortic root level. And that's the one that we'll use to do our AI quantification.
And since you're close to the coronaries, how much do you subtract from
Yeah.
the coronary reversal? What's a normal coronary reversal backflow?
Yeah, I mean, typically,
Since you're very close.
right. Yeah, typically the coronary flow should probably be about 10 cc's, per
Okay.
cardiac cycle, 5 to 10 cc's. By convention, we just don't subtract it. You just kind of incorporate that, and maybe it's because again, when you're trying to image at a location where there's movement occurring, and maybe because of that you're intrinsically going to have some underestimation, and so this kind of fudge factor of saying, well, we're going to pick up some of this coronary flow, maybe that corrects for itself. So we don't really do any subtraction for coronary flow per se.
Any comment for the fellows? When you look at quantitation, there is a regurgitant volume and a regurgitant fraction. All right? Regurgitant volume is a continuous variable. Regurgitant fraction is a percentage from 0 to 100%. Can get more, can get less. Importance of regurgitant volume is its actual value. The higher the regurgitant volume, usually the less the regurgitant fraction, meaning it doesn't go beyond 60, 70%. So the regurgitant volume per se is very important. So if you see a large regurgitant volume, let's say 60, 70, and regurgitant fraction of 40%, this is severe regurgitation. The percentage becomes important when your total stroke volume becomes less. In a depressed ventricle, in a low output state, this is where you start thinking about how much of that total ejection of the heart is regurgitating one way or another. Unfortunately, once you get to lower numbers, the error in regurgitant fraction becomes higher. Why? Because you're dealing with small numbers, so the difference divided by the large number becomes high. So your crux is regurgitant volume. Regurgitant fraction is to modulate that, particularly in the lower flow state.
Yeah, and I think just to kind of echo that, one of the things is we start doing more of these liver patients. You need to keep in mind that regurgitant fraction can be tricky sometimes, because you could have somebody with AI, but it's a liver failure patient who's got a very high baseline flow rate. So they may have 60, 70 cc's of reverse flow, but the fraction turns out very low because their total volume is just so high. So exactly, I think you're right. When you get high regurgitant volumes, don't get misled by seeing a low regurgitant fraction.
And the other suggestion, we didn't delve into it, meaning we didn't stick out our neck in the guideline recommendation. But if you ask me, where does TEE versus CMR fit in your armamentarium? When would you go for one versus another? I think TEE has a great spatial and time resolution. So if the issue is, I don't understand the mechanism. I still have a decent transthoracic, but I don't understand the mechanism of the regurgitation, I would go for transesophageal. If the issue is quantitation, if you have an eccentric jet that's very eccentric and you have issues quantitating, transesophageal is not going to help you quantitate it. If you know the mechanism, if I know it's prolapse, if I know it's a little flail, but it's an amazing, or I have multiple jets, doing a transesophageal is not going to help you quantitate better, right? So if you want this quantitation of regurgitant volume because of all the issues of color Doppler, I think CMR would be better.
All right, thank you.
Great.